heads and hearts, so really looking forward to this time. Leigh, could you kick us off by telling us about your current role and just a little soundbite about how you got there?
Good morning. Technology is a challenge for me. I am the Assistant CIO at Augusta Health. We are a community health system in the beautiful Shenandoah Valley, 255-bed hospital, and we have about 50 physician clinics in Augusta County. And I wound up in this role because I loved helping the helpers. So figuring out how technology can help a health system be better, and just understanding what all that tech is, and then being able to communicate it to the providers. So I wound up being a little good at that and wound up with more work. And I opened my mouth and there was more work.
Yeah, we're just being old-fashioned.
All right, old-fashioned. Good afternoon. I'm Ellen Wiegand. I serve as Senior Vice President and Chief Information Officer at VCU Health in Richmond. We're a comprehensive academic health system and largest safety net hospital in the state of Virginia. I moved here just 2 years ago, almost to the day, from Seattle, Washington, so a big cross-country move, and really happy to be part of the community here in Virginia, and thank everyone for the warm welcome. How I got to this role, I was actually, this morning's keynote was pretty profound and pretty deep for a morning keynote. I was thinking, my parents' story for me was to be a doctor, and I went to college in a pre-med program, but along the way realized actually being a direct patient caregiver was not for me, and I could contribute in other ways through technology. And I've done that my entire career, dedicated my career to helping people through healthcare technology.
That is really cool.
Great. Good afternoon, everybody. I'm Mike Hibbard. I'm the CIO for Bon Secours Mercy Health. So we know in Virginia, Bon Secours, the brand of Bon Secours, and that's why I wanted to be here today. So thank you for the invite. Got to meet a lot of great folks. I'm a nurse by background, and but I always had an avocation for technology. So even in nursing school, I would take programming courses and stuff as electives. So what are you doing that for? It just interested me. So it came around Y2K time, and the leader of IT at the time said, I have a lot of technical folks, but no clinical folks, and I think I might need them. He didn't know why yet, but that's why I came on board there, and experience great every day. And something you all would also echo is we make a difference in patient lives, in physicians, how they care for folks. We are that extension of the caregiver. So even when I or others may think we've had a bad day, we haven't had a bad day. If you think about the patients, they either had a bad day or they've had a celebratory time, with newborns, et cetera. So just reminding ourselves we are an extension of the caregiver.
My name is Geoff Lawson. I'm the CIO at Mary Washington Healthcare. We're a two-hospital system in Fredericksburg, Virginia. We're the safety net provider in the area, and we're very proud of our position within the community. I got an engineering degree and spent several years on submarines in the Navy, and then stumbled into an IT industry after I got out. And I stumbled for about 15 years until I found IT in healthcare. And that clicked for me with the purpose and the mission that I had been missing. And so I've been doing that for another 20 years. I think the thing that really makes me tick every day is how we make a difference one patient at a time every day in our community, and that's what keeps me going.
Okay. Sorry, you all are seeing the sausage get made real time. Well, since there's been so much discussion about AI, we're going to keep that going up here. We're going to talk about two facets of AI. We're going to have a conversation about governance, and quite frankly, if we're overthinking governance. But first, we're going to start with what are we actually doing in each of the health systems represented up here with AI? So what are we currently implementing? How's it going? Any regrets? Has it lived up to its hype? All of that, and this is where we'll start to see these folks comparing notes and interacting with each other as well. Geoff, since you've got the mic.
Okay, so I'm ever mindful of the Gartner hype cycle on AI. And I remind myself and I remind my customers that, we are just at the beginning of this, and it's very frothy right now. There's a lot of companies out there that suddenly change their names and have a DBA with AI in it, and magically that gets them in the door, not to my people, but to every other service line leader in the health system. They're calling directly in, and they're making footholds. They're getting emotional investments made. And then it comes to us. It reminds me yesterday of the conversation. Don't come to me with a solution that you want me to implement. Come to me with a problem, and we'll travel that path together. So for us, some of those frothy things have gotten in the door, and we've taken a hard look at them, and we're actually doing a pilot on one of them, and I'm doing my best to stay neutral, just to see, let's see if this thing shows the promise that the salespeople have made, or let's see if this thing dies under its own weight. So it'll be interesting to see what happens. In the meantime, we're mapping out a recommended approach that we leverage our core system vendors, where the work is happening, where the workflows are being executed. In our case, the likes of Epic, Workday, and Microsoft. Let's always look to our core system vendors first and see what solutions they have that are built into systems that people are already familiar with, that will be introduced as incremental changes, carefully evaluated for their efficacy, rather than bolting something on and asking people to look at yet another set of screens to try and benefit from the technology. So we're working on DAX, and we're working on the beginning elements of some of Epic's features, most notably inbox responses to first draft of inbox responses.
Are those two what you refer to as the frothy things?
No, those are the good ones.
Yeah. Can you tell us about the frothy things?
The frothy things are a proposed reinvestment in some of our camera systems, in-room camera systems, and that are currently supporting virtual nursing and sitter cameras, with solutions that leverage AI to ease the burden on the nurses in a way that I'm not convinced is really ready for prime time yet.
All right, related to AI, because you can't have any meeting without having AI in it at least once. So we might be overthinking it, at least from our health system, because it is really about responsible AI, and I say generative AI, because all of us have had some sort of AI software for years, okay? So whether that's in radiology or early stroke detection, et cetera. I think responsible is the right word, and that's what I talk with attorneys and our compliance folks in that, quite a bit. Don't want to ignore it. There are risks, so don't want to ignore it, but also think through that in a responsible way. I co-chair the AI governance group, which is still evolving. So what do we want to be when we grow up, and then when we do, everything changes in the last couple of months or whatever. So, and we have a group come in that's Avio, which is a health consortium that is helping us around some things. We're having some workshops next as we form this. One is about, and we've placed key folks in this. One is about ethics and transparency. One workshop's around AI and regulations. One workshop is around intake process and approval process. Another one's about transformation. We'll see how that goes. Those are getting scheduled the next few months. We're also in with DAX Copilot for the ambulatory sites. We've had a pilot of 100 providers and it's been very successful, not CFO successful, but provider successful in that it's reduced pajama time, reduced some other things there. So we've started with 100 docs, and we're next moving to 1,000 by February. So that's one of the non-frothy things, to use Geoff's terms there.
Well, we've done a lot of similar things at VCU Health, and I think we took a similar approach to what I heard from the folks at UNOS. We established an AI work group with leaders from across the organization to come together and think about what are our responsible AI principles, what are our strategic objectives, what does governance look like. We used workshop concept to bring people in the room and clear time from the daily calendar to think ahead and not just about in the moment. So we did that over the course of this year, really, and have rolled out now that material that we're using to evaluate AI tools as they come in the door. One of the things we did with that work group, we piloted the Microsoft Copilot products. We have Copilot, just the regular, ask it a question product that's rolled out for everybody. But we're piloting the M365 Copilot, so the things like the Teams notes and PowerPoints and all of that. And to your point, Mike, I think it's been a satisfier for the people using it. People have come up with a lot of really good ideas. We're not quite sure at pencils. If you think about how much that would cost to expand out to the organization, are we going to see that lift back? I think that's the hard question we're trying to figure out, is the investment and that return on investment. We've just signed with DAX Copilot, so we have a pilot of that spinning up. We're doing in-basket notifications. Similarly, we intend to work with our core vendors to roll out the products that they have designed and that we can learn from others. We don't want to be on the bleeding edge. I like to say we like to be a proven leading edge technology, so how can we be a little bit of a fast follower there? And so far that's been working out pretty well for us. I would echo Tripp's comment about check your contracts when you sign for these tools. That's really important. There's a lot of language that gets slipped in there about how your data is used, so please do that.
That's a great tip, thank you. So for our organization, we are trying, and I would say this is from the those of us that can see the frothy things and don't always bring the frothy things back from conferences, to try to make sure that what we're doing is practical and tested. I think what Mike was mentioning about making sure that it's something that's reliable, and Geoff, you said that also in your organization, being able to distinguish between what's hype and what is real. So we've got some nice AI going on in the front end of patient access, so helping with automating some processes around just getting someone in and set up for an appointment, doing that pre-registration process, and then focusing on making their appointment when they arrive for their scheduled visits to be a little bit smoother, already have their insurance on file, and be able to greet them with a smile and have a seat rather than, okay, now it's time to sign a bunch of papers. Are we perfect at that? No, it does actually take a lot of work to get these working properly within each system. So we're focused on those technologies that we can use to leverage some of the ways that will automate tasks that no one wants to do, maybe address some of our staffing shortages because we've been able to reduce turnover or have less need for as many people in some of those clerical and administrative tasks. We have a great appetite right now for some of the radiology AI, which is looking at workflow for the physicians, but then also early reads of any of the imaging to try to route and prioritize appropriately, provide better, faster care because we are able to get the right images to the right provider quickly and get those results back. We have a good indication that that technology is pretty well tested at this point and may be ready for prime time. And then we are, of course, rewiring the hospital so that we can do cameras all over the place. So just like you were talking about with virtual nursing, looking at our future expansion there, we call it virtual nursing. It's really tele-nursing or sort of remote nursing at this point, focused on those discharge processes and other things that a stationary person can just pour into the rooms and provide that service so that when the nurses are actually bedside, they're focused on those interpersonal interactions and not so much on the things that can be done more efficiently by someone that's quickly getting to discharges, which addresses length of stay and patient care and lots of those things. We are looking now at leveraging some of that remote monitoring and remote video to be able to detect. It's crazy, if you haven't looked, like be able to read machines from across the room and send alerts and see that a patient needs to be turned. Someone is trying to get out of bed and may have a fall, we need to get over there. So that is something that's in our near future.
Good stuff. All right, so let's talk about governance a little bit. We've heard quite a bit about it throughout the day, and Mike mentioned what the approach at Bon Secours Mercy is. I cannot remember where I heard this. I was asking Tripp if it came up in a conversation he and I had, and he said nope, so I don't know where I heard it, but I will date myself. I remember working in healthcare when the internet first started proliferating. And darn if we didn't have roles that were, oh, this is the guy who's going to be our internet guy, right? So anytime someone wants to use the internet, we need to think about governance around it. He's going to come help them because it's a big, scary thing. We don't know what we're doing. There actually is a hilarious story about that in front of a School of Nursing class where he Googled the word restraints for the nurses, and what came up on the screen was not what they were thinking about. But anyway, the person who was telling this story about, remember back in the day when we all felt like, oh, we need a guy who's in charge of the internet in our healthcare system, they were supposing that very quickly AI governance will go the same route, where it will be so ubiquitous and all over our organization in ways that we can't even fathom right now, that we are going to quickly throw this notion of governance out the door. So we chatted about this a little bit at dinner, and sorry you weren't able to be with us, but we're just going to have a dialogue up here about if you think we are overthinking it, or if we're not, what's important that survives and how we're challenging it now.
I'm going to start. Oh, I have the microphone. I sorry, we have standing orders to the protocol. So for our organization, our CIO and I have talked a lot about being concerned about getting bogged down in bureaucracy. And the other, so one thing is, how do we make this nimble enough that everyone's not going to just go run out and plug in whatever they want, or talk to a customer success person from a vendor and say, oh, we love that functionality, just turn it on, because we didn't make sure in the contract that they couldn't just turn stuff on. But we also recognize that not all AI is the same, right? So the risk level with any of those clerical or administrative tasks that I was talking about is a lot lower than it is with, say, the virtual nursing ideas that we just talked about that may actually pose some risk if we don't use it appropriately to patient care. So our approach to governance at this point is not to write some big overarching policy to assign the AI guy and have someone really policing that, but to take a more ad hoc approach where when someone, so you want to buy a thing, anyone ever have things that they want to, every day, so someone has a thing that they want to get, and then assessing what is the risk there. I loved the talk yesterday about scoring that the UK was doing and putting some sort of, I don't think we need parental advisory lyric warnings on our technology, but something that indicates whether the technology is used for direct patient care, what the risk could be, and doing a more thorough job with those. But for the ones that are, we have right now our revenue cycle leader who's amazing and loves technology. She's looking at some things that would simply automate a lot of workflows for her team where they're struggling to keep up with the volume, and it has to do with claims processing. We're not going to bog her down and trying to give that a try, because at the very least, she says she can just implement the paper process again and catch up. So our approach to date has been, and legal's on board with this, is let's look at each use case as something very unique and assess the risk, and then decide how we want to govern that particular one. And from that, we hope to learn enough that then we could, over time, start making some broader ways that we want to govern AI, and maybe we come up with categories or something. But right now, recognizing we don't know enough to be able to say, here's the policy and this is the process, and it's going to make everybody happy and get the job done. I don't think we know that yet.
Yeah, I would largely agree with that. I think the technology is changing so quickly. It is so highly available. all of your team members are using this technology. Maybe not all, but a lot of your team members are using this technology in their day-to-day lives. We probably all are in some form or fashion. So I think that with the risks that it brings to an organization, we think about IP risks, reputational risks, data, patient privacy, all of those things. For us, it was important to quickly and early establish some guidelines for use. So we have put those out for our team members. You know, what can you do and what can't you do? You know, you can't use a publicly available AI tool for work. We just don't allow it. But you can use Microsoft Copilot and use those tools because we know that those are protected. So we've put some, I'll say, guardrails in place to try and educate people about what they're doing, not just at work, but also at home. You know, you could be putting your own information at risk in some of these tools. So we have done some of that. We did formalize a policy this year as part of that AI work group I mentioned, and it's pretty simple. It's like, don't break the laws, adhere to our guidelines, don't expose us to risk, and report concerns, right? It's very short and sweet, but it gives people just a moment to think about, okay, what is it I'm doing here in this tool, both at work and at home? In terms of governance, like project evaluation and whatnot, we came to the same realization that there's things that are moving so fast, we are going to use our existing technology and data governance to work through those. These are the same kind of questions that those groups are already answering. You know, is this technology of value? What are the risks? What are the costs, et cetera? So why create something new? And that's where we have landed for now.
All right, so related to governance, so I spoke briefly about AI governance. We've been given the charge by the executive team of merge all these other little governance committees into something that makes sense. So that's the next step. For example, we're going to merge final approval, so this is pending. Nobody's broadcasting. Okay, so we intend to merge the INT strategic governance, the clinical informatics governance, and bring the clinical informatics and the IT strategic governance into one and rebrand it as something called healthcare technology. That's going to be a little bit of a leap for folks, but there's benefits in that too. So for example, if a clinician is bringing something for a decision, for vetting, whatever, now I've got the leader of HR in that meeting also, because it was in the IT group, the leader of marketing. They may be able to think, we hadn't thought about that. Do we need to help you with a campaign? Or what does that mean for people? And what do we need to do for the people there? So that's a journey we're on right now. I envision over time, once it gets evolved a little more, AI governance will probably fold into that as well.
Thanks. We currently have a data governance group that we're going to broaden their purview and ask them to take on the AI challenge as well, given its very, very similar challenges. Both, you know, at the end of the day, it's how are we using our proprietary data to ultimately make better decisions. I agree with Ellen. It's the guardrails at this point, just to give basic do's and don'ts, and then just to make sure that we're protecting our sensitive data and protecting our patients' data. And beyond that, leveraging existing governance structures to make sure that we foster this new technology forward in a safe and effective way, and in a way that's not inhibiting the potential opportunities as well.
Can I have an addendum? Yeah. And the elephant in the room, we've talked about, do we ban certain things? We have put some guardrails in place, et cetera. But the elephant in the room is, we know if we lock it down too much, people are going to do the same thing on their personal computer at home. And there will be patient data in there, there'll be all kinds of stuff. So I'm convinced that's happening today, and I think probably all of you are too. So how do we educate, train on the risks of that too? Thank you for letting me do the addendum.
Sure, that's what we're open for. Any last words on that, or? Okay. All right, we're going to move to a couple questions around the personalities of these folks up here and how they work in their organizations. So I'm going to ask each of them to describe how they think they're viewed through the eyes of their CEO. So we've just been talking about some really complex stuff, and it seems like every year at HIMSS, we're like, this is the year that technology is really going to change healthcare. And we were hiring chief digital officers, and then we don't have them anymore, and there's been a lot of back and forth. But gosh, it does feel like things are going to start moving much more quickly. That probably excites many CEOs. The price tag probably also terrifies many CEOs. So with that backdrop, Mike, we'll start with you for something fun and mix up the order. How would your CEO or the C-suite describe what they most value about you in your role of CIO?
And it's a timely question, because in the past they're asking me to look more future, more out in the future, and at times we're all in the midst of a fire drill, or we're in the midst of an implementation or something. So they expect that I'm looking more future oriented as opposed to in the day-to-day as much. So that's a shift. Budget, good. All the other things that were on there are good. It's just that's the ask.
For me, it's enabling the health system strategies with an eye on financial stewardship. There's that constant push and pull to make sure that we're squeezing the benefit out of every dollar that our health system invests in us, which ultimately is charged back to every one of our service lines. So when they see what's being charged at the end of the year, they're asking questions in their head. Have I gotten the value out of IT that I needed? And I want to make sure that they're having the right conversations with the CEO to say, the right answer. So that's really it. And the day that he and I don't see eye to eye on that value equation is the day that I know my time is short. So it's something that I constantly think about, and I think that's appropriate.
Yeah, I think our CEO, he's my boss, he is looking for a business leader, someone who can understand the problems of the day and of the future and work towards solutions that will sustain the organization. I think cost management, we talked about financials, that's kind of table stakes. We spend a lot of money, healthcare margins are really tight, and so it's on us to make sure we're spending those dollars in the best way and understanding what levers we have to pull to reduce costs so that we can save money. I was talking about saving money in one place so we can invest in another. All these new technologies, it's gonna come with incremental costs, and we're not gonna be able to grow IT budgets to cover that. So where are we gonna find the lift? We just were having an executive committee meeting the other day, and folks were like, you are like the glue. We're like the glue in the organization, because often we're the folks who have kind of that biggest, highest level picture of what all the pieces and parts do and how they interact and what all the functions need to happen to make the organization really run, because we have to provide them all tools. We have to work with everybody to make sure their needs are met. So we sit in a unique spot and can offer really unique solutions because of that.
Thank you. Yeah, absolutely what they said, and I love calling finance the table stakes, right? Because we don't get to keep showing up if we can't do that at this point. And I would say, so in addition to everything that my wise colleagues have shared, one thing that I feel is a transition recently is really for the CEO to be looking at IT for how to humanize technology. It feels like over the last few decades, EHRs were done to us with meaningful use and all the regulation, and now it's flipping a little bit where figure out how to crawl out of that, figure out how to bring well-being for providers and user experience and patient journey and all of these topics that are so hot right now, but relying on technologists to say, okay, well, you've been running these things for years. How do you now make it a completely different experience? And for challenging us to be so good at human-centered design, understanding the technology and how people use it, those types of topics that are daily now for us, and thinking about how we're going to practice medicine. And of course, it is all in, as you mentioned, with every single service line. No one does their work without technology behind it. So it's a real challenge, and I think a pivot point where I feel almost like the last 20 years of implementing EHR has got us to this point where everyone's really unhappy, and providers are burned out, and nurses are burned out, and there's not these efficiencies, and everyone's frustrated that we have all these tools, and I can just order whatever I want from Amazon, and it's on my, why can't you do that in healthcare? And the eyes are turning to us to say, oh, you guys know this really well, so now make it really easy to use, and that consumerism, all of that. I feel like that is one area that the CEO is not looking at the chief nursing officer or the chief physician executive to figure out how to humanize technology, but it's coming from us.
How many times over the last day and a half did we hear that saying, healthcare isn't easy? You know, Berkshire Hathaway and this company got together to create a healthcare startup, and it didn't roll because healthcare isn't easy. So I love that question about how come I can just turn on my iPhone and it works, and I can't order narcotics just like in the same way. And you're like, there's, which of the 50 reasons do you want me to give you? So lots of challenges being a CIO these days. Every now and then, though, one of those maybe what you called frothy projects, or something else we do, because we are doing a lot that's not AI. Meanwhile, the Epic upgrades still have to happen, or whatever core system we're on, or we have infrastructure challenges, same old, same old. You want to implement something cool, and you figure out you don't have wireless bandwidth to accommodate it, or things like that. So if any of you have some quick and easy things that you did over the last year that you were like, wow, that was low spend, low drag, high value, we'd love to hear about it.
All right, I'll start with some. So I loved hearing about the gross terminology. I think frothy and gross are the two terms I'm going to walk away from this conference with. But we've been doing, so we called it waste reduction, and I'm so jealous that we didn't come up with gross, because it's the same thing, but it sounds much cooler when you do it in a fun way. But a lot of automation, and I'm extremely proud of our IT team for thinking that way, that we need to be leaders in that. So even within delivering IT services, how can we stop doing some of those mundane tasks? And they've gotten really nimble about turning around workflow automation, even things like the responders for emails. I mean, that seems like a basic, but we still need it. And now that we've done it well enough within IT, where I feel like we can actually go out and share some of this, we're getting lots of requests, like even yesterday from hospice, asking us to help understand some of the scheduling that's going on around campus, and applying those same gross methodologies to that, and say, okay, how can we go visit with these folks, understand their workflow, and automate just even a couple of things so that they feel like we made their days easier. So that's where we're focused, is really those minor automation and across the entire spectrum. So anyone that tells us they've got a pebble in their shoe right now, that something is slow or cumbersome, we're going to have a SWAT team try to fix that.
Yeah, we've done some similar things with our EHR usability project. We have a Scrum team that's kind of working specialty by specialty on optimization and enhancements, and kind of remove those rocks in the shoes. And I refer to that, it's our pick and shovel work, right? It's the stuff that you do it day in and day out to just make things that little bit better. That makes a huge difference. But one of the things I think that has made the most difference was not technology at all, but we created a new role called a provider support coordinator. And these are folks, they had been trainers, and we sort of reimagined what that role could be as really at the elbow every day, out on the floor, working with our providers to get them from, onboarding into productivity. We're an academic health system. We onboard a lot of providers, a lot of residents, and having just that handheld touch to get them into flow has been a huge lift for not no really incremental spend and no new technology, but just a different way of interacting.
So quite a bit of push for revenue improvement. They want IT not only to meet the budget, which is table stakes, but how are we going to do growth? How are we going to make money out of IT? What are we going to bring to the bottom line? So a lot of that right now, the last year or so, and it's still in progress, is yes, we sell Epic Community Connect to other places. We're now pushing, we're going to be able to sell where it's appropriate, where people want it, ERP, document management, other systems, and be that system provider, if you will, for them. So it's about revenue generation.
Yeah, that's an interesting one. Good luck with that. I think the original question was small projects, big impact. Is that right? Okay. Over the past 5 years, we've grown by close to 30%. Most of that is through practice acquisitions. Not because we were being aggressive and going out and buying them up, but because one by one, these practices are raising their hand saying, we can't do this anymore. Our pockets aren't deep enough. Our revenue model isn't sustainable. It's too hard to recruit physicians. And they basically say, please pick us up. Usually the owners of the practices are looking for their way into retirement, and we give that to them. And at the same time, we're preserving that physician base that's so critical to our community. When you grow through acquisitions like that, every time we onboard a new practice, they want to do things their way. New EMR? Yeah, but we still want to do everything the same way we were doing it before. So, and honestly, we were very accommodating. We wanted to make that transition as smooth as possible. One thing that got lost in that mix was the insistence that a simple feature in Epic called FastPass got turned on. With FastPass basically puts you if you're on a waiting list, which would normally be on a clipboard at the front desk, because you are waiting for an earlier appointment, FastPass will automatically send you a text. Hey, a new appointment opened up. Do you want it? Yes, that's it. It's just a SMS text, simple SMS text interaction, and you just got moved up in line. Without that, we were having cancellation rates leading up to a day of vacancy of about 10% of available appointments. We're staffed to do those appointments. We're modeling revenue and income based on those appointments, but we're not filling those holes. And so once you turn on FastPass and you say, this is a non-negotiable, this is just the way we do work, this is a huge satisfier to patients, suddenly our vacancy rate goes down, our revenue goes up, the physicians' RVUs go up, so they're reasonably happy. And that was a very simple body of work to do, and it made a huge difference in our revenues for our ambulatory practices.
I'm going to steal that from you and start with you this time. How about, hopefully folks can hear me through that one. How about the opposite? Are there any projects that you started this year that you were like, oh, this is going to be low drama, not a big deal, and they just did not go that way? Ended up being more costly, more complex, more political, or something like that than what you had counted on?
Yeah, I was trying to think of one that did not turn out like that. One that was more simple than we thought it would be. They all end up more complicated than we want and hope them to be. One that we're working on now is clinical communications, unified communications, which everyone will recognize is very complicated. It's even more complicated than you think it should be. We have many work streams working on technology and process and communication standards, and it's been years in the making with a lot of really good work. And we're about to launch a project, not the tool, but a project to get us to where we think we want to go. But there's all of these projects end up being such a small component of it is the actual technology. We know what technology we would like to use. We actually bought one a few years ago that we didn't end up standing up. But it's all the work, the process, and the team roles and responsibilities, the clinical workflow changes, all of that around these projects that make them so terribly complex.
Go this way. All right. So the project that I mentioned earlier that's in the revenue cycle space around patient access, that was going to be a 12-week implementation and then magic, right? So, or I think they came with the magic, and it wasn't magic. It was actually robotic process automation doesn't happen because like really smart robots show up and fix everything. It's you have to teach it and train it. And we ran into so many different issues. Even my favorite example was that it does screen scrapes and our fields were green in color and it couldn't scrape green fields. So they set up the screen scrapers, everything's gonna go fine, and nothing was coming out because it couldn't see, and the robots are saying there's nothing there. So we're now 2 years into that of teaching the technology, and we've made good improvements. It's working very well for us, but it took a long time to figure out, because it wasn't actually magic. You had to teach it how to do each piece and train the system and really understand your processes. So that was one that got, fortunately the leaders on the operational side didn't give up, because I think that would have been one that we may have just jumped out of because it was losing its, the juice was not as much as the squeeze turned out to be. That was a tough one.
We've got one called Project Voyager, and it is a voyage. So, in principle, this sounds like nirvana. This sounds like where you want to get for clinicians. So a nurse will have one, and I think we'll still get there. I'll get into there's cost overruns. There's all kinds of stuff, which is making it harder. But a nurse would have one device that she would then have with her that has on it Epic Rover to do charting, has also on it communications. We use a product called Perfect Serve. So if they're at the bedside and they need a cardiologist, they don't have to get somebody to call. They just type in the word cardiologist on their phone, and who's in that schedule then can appear, and the nurse never has to leave the bedside. The third piece is for the folks that nurse is taking care of that day, they'll also get EKG alerts. So if they're a telemetry patient, and they'll be able to tell, in a lot of cases, what is artifact versus what is real. And then the fourth piece will be nurse call, so that Mrs. Smith calls and she's 5 doors away. Instead of the light just flashing and a nursing station call go on, but there's nobody in the nursing station, now the nurse can say, Mrs. Smith, I'm 5 rooms away. Can it wait 5 minutes or not really? And now that patient engagement, that patient satisfaction from how we respond. It's great in principle. It's very costly.
Yeah, the one project this year that's been fraught with risks is really the intersection of a medical oncology group acquisition with 340B. So all the infusion protocols and processes that were occurring in an outpatient setting, we had this brilliant idea, well, we already have an inpatient infusion center, and they need to be outpatient department of a hospital. So let's just tell that ambulatory infusion center that now they're an outpatient department of the hospital, and we'll just start doing we've got the build in Epic already done, so they just need to change the way they do their work. Well, as you might imagine, it got very complicated very fast, and something was said yesterday, it's not change management, it's change leadership. And it's that collective leadership of the operational area, IT, that is the secret sauce to success of this type of project. Technology is a small part of it, but it can also be a scapegoat, and that's where things get really touchy. So I think first and foremost we need to be change leaders. And the technology kind of comes along a lot more easily if that part is handled.
That made the hair on the back of my neck stand up because I also have a 340B concurrent with an oncology practice acquisition in my history. Yeah, danger, danger, Will Robinson. Okay, we have the 10 minutes marker, so we're going to move to a little bit more of, again, how a CIO ticks. Just curious, how many folks in the room are thinking about, I think someday I'd like to be a CIO? Okay, good. Actually, not as many as I thought there might be, but okay.
Ellen says that's smart.
Yeah, well, okay, maybe that's, maybe they're hearing all this and they're like, not signing up for that. But the next question, so we're going to have 2 questions at the end, and hopefully we'll get to both of them. Knowing what you know now, what advice would you give yourself 20 years ago? And then the next question is, for those who may be interested in being a CIO one day, what advice would you share? And I think maybe some of those questions might get similar answers.
All right, I guess I'm up first. We passed the mic. So my husband and I celebrated our 21st anniversary this past weekend. And we were thinking, oh gosh, it's been such a crazy adventure. And so thinking about this question 20 years ago, what advice would I give myself? It would absolutely be not to worry so much. You know, not to try and control things too much, to take every opportunity to learn and embrace all the pivots and the moving and the different roles, because the earlier parts of your career are your time to explore what you want to do, what are your interests, what are you good at, what really lights you up, and gather up all that experience. And the jobs, the roles, all of that will follow. If you are open to it. And so that would be my biggest advice to my former self.
Okay, I love that. Do you want us also to share what was the second part of that advice to others, or?
Oh, I missed that.
Do you want to go ahead and do that? Okay. No, not being on the spot.
Well, maybe that is my advice to others too. You know, just to say yes, be open to opportunities, be curious, be a lifelong learner. For those of you who are looking to be CIOs, I mean, I've jokingly said this is the best job you could have because it is new every single day. The job has changed so much. I was talking to a woman I mentor yesterday, and she was like, I don't know what I want to be in 5 years. I was like, who knows what the roles are, what's going to be in 5 years? Who knows? The CIO job 5 years ago was totally different than it is today, and I'm sure it will be totally different than it is in 5 years. So stay curious, keep learning, build really strong relationships across the industry, and have a lot of fun.
Awesome. I love that. So for 20 years ago, I would tell myself just to be a little more self-confident because when I first started attending med exec meetings, I was a 5'4", 30-year-old blonde woman, and I didn't know who won the Florida State game this weekend. I was down in Jackson, Mississippi, so it was very nerve-wracking to be in a room full of people that they all looked so professional and they were so mature and all of these things. And I realize now that the industry has changed a lot more in the direction of the way that I think and communicate and the way that I like to work. And so I think a lot of my success was because I was doing things that felt a lot more, they connected with people, and the way to explain things in a way that resonates with folks was really a strength, and I didn't recognize that for the first few years. And so if you're doing something that seems to be working and maybe other people don't do it that way, just think about the fact that maybe that's what makes you really, really good at what you're doing, and capitalize on that and embrace it and be your own brand of crazy. And I would echo being curious, because that's the way that I live my life, is being curious. And I think no matter what the job is, even if it's hard, and yeah, we all face stressful moments, and the job is difficult, and there's politics and all those things. If you can really figure out what you love to do, and you want to do that every day, you're going to love going in there and facing whatever difficult meeting it is or whatever challenge comes your way. And so that curiosity and passion, I went from administration to revenue cycle to IT, and I just love where I am right now. I went from academic medical centers to a community hospital. I love that as well. So play around, figure out what you don't like and what you do like, and just follow that curiosity, because that's what's going to make you want to show up with a big smile and get the job done, whereas someone else may, if they don't care, if they're not curious and they're not invested, they're not going to be the ones that are there doing the best effort.
So Ellen used the word I was going to use, and we all have curious. So curious 20 years ago was different than it is today. So curious 20 years ago, I was an ED nurse, working night shift, but flexible, like, oh, you want to try something or you want to do something? And so saying yes, and what does it really mean? You know, kind of thing. Curious right now is, what does tomorrow hold for all of us in this ever-evolving space? So I think keeping that curiosity is key, and we're getting the red signs here.
So 20 years ago, your advice would be go into the tech role. Yeah.
Yeah, specific to, preparing to be a CIO, I would say be an extrovert. If you're an introvert, be an extrovert anyways. You can adapt. You can, the best advice I got from the CIO back at Cone Health was communicate, communicate, communicate constantly. Get your MBA, just get it done, get it over with. You might actually learn something. A lot of folks who don't come from the clinical side of the house have very weak muscles outside their IT expertise that may have gotten them to where they are. So getting that MBA or getting that MHA is extremely helpful. And it'll kind of round out the tools in your toolbox. Most importantly to me is empower your experts. We cannot be experts on everything. We cannot micromanage. It's just not even possible. Even if you wanted to do it, you just can't do it. So rely on the experts, defer to them for some of the decision making, probe them, make sure they have good quality decisions. But at the end of the day, they're the ones who have to run the stuff, and so their recommendations should really count. As far as the 20 years ago advice, look beyond your vision statement for your health system or whatever company you're working for, and really dig in, again, with that communication with service line leaders to say, okay, what does it mean to be creating outstanding health experiences? Let's talk about what that really means, and let's dig down to the strategies and the tactics, and then let's go after them together. Now that we've talked about them, communicate. Let's go after them together, because otherwise you're just kind of reacting to things. Map out your course, and then go after it, not by yourself, but with all of your colleagues that you've gained consensus around you with.
Jokingly, last night at dinner, when we had this conversation before we put the boundaries, what work advice would you give yourself 20 years ago? We got answers like, buy NVIDIA, buy Google. So I think we would all give ourselves that advice as well. Well, thank you everyone so much for allowing us to chat up here. And I defer to the leaders to tell us, do we have time for Q&A, or you need us to wrap up so we can get back on track?
We're communicating. We're okay for a few minutes? Okay, yes?
Okay. All right. Any questions? Yes.
So I'm just curious on what you all's feelings or thoughts are. And again, this might be a little pointed, but like Ellen mentioned, you guys see it all, you hear all the challenges and problems across the ecosystem. What are your feelings and thoughts on earned wage access as it relates to healthcare workforce burnout and wellness, adding a technology that adds humility, right? Because it shows through employees that you care. What are your thoughts on that? Other tech verticals and industries are offering this, but we are seeing healthcare is kind of late to bringing that on board.
Okay, so I think what you're going to need to do is tell us what you mean by earned wage access, and then maybe also therein you have your answer of, no, we're not thinking of it yet. think we've heard that called something else, but yeah. Rapid pay or something like that.
We are.
Yeah, we turned that on. It was one of the vendors that we do payroll with offered rapid pay as a solution, and HR went, yes, and so we did. I mean, we signed a contract, let them turn on all the AI. I'm just kidding. So it was really actually pretty simple, and we're doing that as a recruitment strategy to allow people to get their pay. Once you work your shift, you can get your paycheck. It was a light tech lift. It was an HR thing.
Maybe that should have been one of the ones we mentioned, I loved it, Leigh, when you said 12 weeks in magic. I'm like, okay.
Yeah, just one additional thought to that, because it also makes me think about, the transition and the attractiveness to a good segment of our workforce, like the gig economy. We, for example, have PRN nurses that look up and down 95 at the health systems and see which ones got the premium pay shifts that are up for grabs, and that's where they go. And so we don't like that, and we do our best to make sure that we are their healthcare employer of choice. But at the same time, we know we need to accommodate that segment that prefers to do their work that way. So between that rapid pay and being attractive to PRN employees, it sure as heck is better than paying for travelers. So that's something that we're challenging ourselves to be more flexible on.
Hey, thanks, guys. Other questions? Yes.
So, and this is, I kind of clued right into the nerd out about this stuff, Geoff. You were talking about the acquisitions and letting them kind of keep a lot of their own practices. What have you seen as far as operational challenges by not homogenizing their IT solution?
Well, we move them onto Epic day one. But there's still a lot of variation, which in the build, and that's especially true across specialties. So we're really going back and sweeping back around and challenging ourselves and challenging our operational leaders. Where would it be more beneficial to standardize some of these approaches? Right, and I think it was mentioned yesterday, right down to forms. I mean, forms ought to be the same. And really, if you put the patient at the center, we want a similar brand experience across all of our practices. We want them to know what to expect. Yes, that's correct. Yeah.
If I might add, the consequences of that are very far-reaching. So anything from, move floating staff from a clinic to clinic, supply chain, supplies, all of that infrastructure that goes into supporting that clinic. There's a reason why those providers can't sustain that clinic. It's too expensive. The only way to do it is to make them part of the health system, which then entails all the standard process around it. So that's something we try to push very hard on. Your health system won't sustain, picking up all these clinics and operating business as usual.
Questions? Yeah.
For IT staff? Is that what you're asking?
IT, or whether it's kind of bridging the gap between IT and the business as a business analyst, or just where you kind of look and say what's missing in my organization.
Well, and I don't think this answers it directly, but when you think about what's needed is really a strategic thinker. So CIOs, et cetera, that are leaders, I surround myself with smart people that know how to do that other stuff. But if you can't have a big picture thinking of a move forward kind of thinking piece, then you're not going to thrive. Did that come close? Okay.
Yeah, the one other thing that came up as you asked that question for me is it's the perennial search for folks with good critical thinking skills, with good attitude, a aptitude to learn, and being willing to understand that we didn't hire them to just fulfill a specific task for which we needed somebody to come in the door to do that. We're hiring them to be flexible and to be deployed to wherever there is the greatest need, and being able to relearn and retrain themselves at our expense as they progress through their career with us. Too often we hire people for the specific job, and we don't think about what is the value of them being able to move around and be flexible. So that's something that I've been stressing very, very hard with my hiring managers. Don't hire somebody for that position. Hire it for the position three levels up, they need to be capable of that advancement.
And be okay when they make that advancement. Don't be selfish, be okay. They're moving on to something else, be okay with that. Because that shows you help them grow.
Hey, I'm guessing that's probably it for us, because I think we're running a little bit over. So thanks very much, everybody, and thank you, panelists.